In today's discussion at Medical Sciences by Naftali Muhumza, we are going to take you through preeclampsia, or what we can call blood pressure in pregnancy. So we want to see the differences between preeclampsia and eclampsia with hypertension in pregnancy. And this preeclampsia we are discussing today is the most common cause of maternal death in the world. So when you hear that the lady has died during pregnancy or during delivery, this is one of the most common cause of death in pregnancy. So if you're there, you are expecting to be pregnant or you are already pregnant, this is a must know so that we can prevent this common vice which has claimed our life. And as we begin, if it is your first time, please subscribe so that whenever we release other videos, you're notified. Then you can like the video, then share to many others so that they can learn from us. So, as we're going to say that preeclampsia, this is hypertension. This is hypertension in pregnancy, which its onset is after 20 weeks of gestation. So if you're a pregnant mother, after 20 weeks after getting fertilized, then you get blood pressure greater than 140 over 90 millimeters of mercury. So blood pressure greater than 140, that is systolic. Then diastolic greater or equal to 90 millimeters of mercury. That is what we are referring to as preeclampsia, and it is always characterized by either proteinuria, presence of proteins in urine. And how do you know that there are proteins in urine? You find you are producing urine with foam. It forms, there is formation of, maybe we can call it bubbles on top of the urine. So as you're urinating, you find there is much formation of foam or bubbles on top of the urine. That's when you can go to the lab and we check if there are presence of proteins in urine. So it is characterized by presence of proteins in urine together with either, it can be with or without organ damage. So this is what we refer to as preeclampsia. The onset is after 20 weeks, so it majorly occurs in the second, towards the end of the second and then the third trimester during pregnancy. That is after 20 weeks. So if you're pregnant and we test your blood pressure and we find it is below 20 weeks, that one we can prefer it as it has been there. That is hypertension. But preeclampsia starts after 20 weeks of pregnancy, characterized by high blood pressure. If you find it is between 140 to 160, then 90 to 110, that is moderate. Then greater than 160 over 110, that one becomes severe. It is the one which is always characterized by organ damage. You find your liver is damaged. You find there is kidney damage, brain damage, and heart failure. So there are many complications as we are going to discuss with you. And as I told you, this is one of the leading causes of death in pregnancy. So after knowing what preeclampsia is, you can ask yourself, what is eclampsia? Eclampsia is, so if we have eclampsia is preeclampsia plus convulsion, or what we can call seizures. So if a pregnant woman is hypertensive, there is the proteinuria, presence of proteins in the urine, and you find they are convulsing or with seizures, that is what we call eclampsia. And this is a medical obstetric emergency. This one, the pregnancy has to be terminated immediately after stabilizing the mother, despite the age of pregnancy. So we're going to see what are the signs and symptoms. How do you know that someone, signs and symptoms? How can you know that someone has this common device pre-eclampsia? And one of the signs is the frontal headache. Every time you feel frontal headache, there is headache, there is always edema. Edema, this is what we call swelling. This edema can affect the lungs, it can affect all the body, whereby you find there is swelling in the lungs, swelling on the face, legs, hands. You find this is one of the signs and symptoms. And this swelling of the lungs, what we call pulmonary edema, is characterized by shortness of breath. You find there is difficulty in breathing, shortness of breath, that is shortness of breath can happen, which we term as dyspnea. Then there is other complications we can find. There is oliguria. In severe stages, there is reduced urinary output. You find you have been urinating maybe 4 times in a day or 5 times in a day, but this time it is once a day and with reduced urinary output. That is what we are calling oliguria. So this is reduced urine output. So if you see these signs, then another one is foamy urine. This urine is reduced but with foam. It has a lot of foam on top. That is another sign and symptom. Then another sign you can know is epigastric pain. Epigastric pain. You find the pregnant mother is telling you every time they are feeling pain in the right upper quadrant region, or sometimes they call it epigastric pain. That is one of the signs we can know that someone might get pre-eclampsia. So these are the signs we can see on a patient. So if they continue to progress to the severe, someone can end up with confusion due to cerebral edema. Then it can progress into convulsions. And convulsion, that is what we call eclampsia. This one, it is very emergent. It is an emergency situation that you must stop the pregnancy before we lose the mother. So these are the signs and symptoms we can always tell that either the mother is tending to have preeclampsia. The major ones is swelling, then the epigastric pain. That one means the liver is affected, then reduced urinary output, what we are calling oliguria. Then with the foam, meaning that there is presence of proteins in urine. So after looking at the signs, we can also look at the risk factors. What are the risk factors? Who is at a risk? Because the cause of preeclampsia is not well known, but we can tell by looking at the risk factors so that we can always prevent it before it happens. And one of the risk factors is getting pregnant when you are elderly, that is having age greater than 35. Getting pregnant when you are aged greater than 35 is one of the risk factors, or getting pregnant when you have age less than 18 years. This is one of the risk factors. So you find you are 40 years and you're getting pregnant, some or those of the risk factors, or a teenager getting pregnant. Then another one is having the first pregnant when you are prime gravid. So first pregnancy can be one of the risk factors because your uterus is not yet used of this fetus who has come in. So first pregnancy can be one of the risk factors. And also there are some ladies whereby you find every pregnancy belongs to different men. You find the first one was for Samuel, the second one was for John, the third one was for maybe for Mukasa. So you find pregnancy with the different men. Getting pregnant with different men is one of also a predisposing factor of getting preeclampsia during pregnancy. And another risk factor is multifetal pregnancy. You find you have twins, you have triplets, you have 4 babies in one womb. This one can also be a risk factor of preeclampsia. Multiple fetus during pregnancy. Then another risk factor is pre-existing conditions. If you are having high blood pressure, that is hypertension, you are at a risk of getting this preeclampsia during pregnancy. Also, people with diabetes mellitus. If you already have high sugar levels, you are also at a risk. Then last risk factor is obesity, whereby you have the BMI greater or equal to 25. If your body mass index is greater than 25, means you are obese, so you can be at a risk of also getting preeclampsia. So these are some of the risk factors we can see which can result into preeclampsia. And another one which is not so common is someone with lupus erythematosus. This is an immune disorder which can trigger blood pressure in pregnancy. So always take note before you get pregnant. If you are having one of these risk factors, it is either your first pregnancy, or you are getting pregnant at old age, or at a young age, you are at a risk, or you are getting every pregnancy you get is from different men, still you are at a risk. And also having pre-existing conditions like hypertension, diabetes, systemic lupus erythematosus, which we have said is an autoimmune disorder, then you are obese, can also be one of the risk factors. After this, knowing this, we want to see how does this preeclampsia we are talking about, how does it come about? How does it start and how does it manifest? And what could be the complications if not treated? That is what we want to look at. So we are looking at the pathophysiology. And complications. So with this preeclampsia, it develops. We know that during pregnancy, the fertilized fetus is implanted in the endometrium or the uterine wall, and the blood supply, with the help of the trophoblasts, if this is a fertilized ovum, it uses the trophoblasts to get embedded on the walls of the uterus. So during implantation, in case the fetus using their trophoblast, they have not differentiated well, and there is shallow implantation or shallow placentation. This one, if it is not well differentiated, it can result into shallow placentation. The placenta becomes shallow, and this placenta, the blood supply, it is supplied by the spiral artery. This one we call it spiral artery. So spiral artery is the one that supplies the nutrients from the mother to the fetus. And this spiral artery, when the mother is not pregnant, it is of this size. It is of small size. But during pregnancy, we see it remodel. There is what we call arterial remodeling, whereby it dilates to increase blood supply to the fetus. So these spiral arteries within the endometrium and the myometrium, they supply the fetus via the placenta, and during pregnancy, they dilate or they increase in size so that there is increased flow of blood to the fetus. So if the fetus is here, there is increased supply of blood containing oxygen to the fetus so that it can continue to grow, so that we can see growth of the fetus. So with the preeclampsia, what happens? The artery fails to dilate or fails to increase in size so that there is increased blood supply to the fetus. And what happens? Because of failure of this spiral artery to dilate, or it becomes narrow, and there is restricted blood supply to the fetus. So blood supply to the fetus is not sufficient to supply nutrients and oxygen to the fetus. So you find our fetus is suffocating. There is not enough blood supply and oxygen supply with nutrients to the fetus. And what happens? We are saying due to failure or due to narrowing of the spiral artery. So narrowing of the spiral artery. This spiral artery is the one that supplies blood to the fetus. So when it is narrow, or another factor can be due to shallow placentation. When the placenta is shallow and the artery has remained small, that there is little blood supply to the fetus, this one leads to decrease in blood supply to the fetus. So there is decreased blood supply to the fetus. And when there is decrease in blood supply to the fetus, what is going to happen? There is also reduced oxygen supply. And when you reduce oxygen supply to the fetus, this one, there is decreased blood supply, so no nutrients reaching the fetus and no oxygen reaching the fetus. So due to lack of nutrients and oxygen reaching the fetus, it is going to cause what we call intrauterine growth restriction. So the fetus is not going to grow very well. And that term is known as intrauterine growth restriction. So the fetus is restricted from growth due to lack of nutrients and oxygen because of the narrowing of the spiral artery that supplies blood from the mother to the fetus. And what happens is that when there is hypoxia, that is reduced oxygen supply, there are no nutrients. This situation is going to trigger production of inflammatory factors. So there is production of inflammatory factors. And these inflammatory factors, they are due to oxidative stress. This is due to oxidative stress. This oxidative stress due to lack of oxygen to the fetus is going to produce these inflammatory mediators. And these inflammatory mediators, what happens? When they go to the blood vessels, if this is a blood vessel with the endothelium, so the first thing these inflammatory mediators do is they are going to cause to start destroying or they are going to damage the endothelium. They are going to cause the endothelial damage, that is the lining of the blood vessels of the mother, not the fetus. This one affects the mother. So you find the blood vessels of the mother who is carrying the fetus are going to be damaged or destroyed. And what happens to this damage is going to cause leakage. It is going to cause increased permeability. This one leads to increased capillary or blood vessel permeability. And when the blood vessels become permeable, by creating pores or leakages, we are going to see the intravascular fluid leaking out into the interstitial. So there is leakage. This increased permeability leads to leakage. Leakage of the fluid from the blood vessels containing even proteins. So when we lose proteins and fluid to the surrounding cells where the blood vessels are moving, this one is going to result into edema. Edema, which we call the swelling. So if this increased leakage of proteins and blood fluid from the blood vessels to the surrounding area, it leads to what we call edema. And this one can result into generalized edema, that is swelling of the face, swelling of the lower extremities, that is the hands and the legs, and even it can affect the lungs. So this edema can be either pulmonary edema that is affecting the lungs, or it can be generalized. So that is how edema develops during preeclampsia due to the leakage of the intracellular fluid to the surrounding interstitium, leading to the swelling of the lower limbs, that is the legs, the hand, the face, and even pulmonary edema, that is swelling of the lungs, leading to shortness of breath. So you find there is difficulty in breathing due to this leakage, due to increased capillary permeability. And another thing, what happens due to the damage of endothelium, it is going to cause narrowing. The lumen of the blood vessel is going to narrow, and this narrowing of the blood vessels is the one that results into hypertension. This one results into hypertension due to the narrowing, because when the blood vessel lumen narrows, there is much force required for this blood to be pumped, and increase in the peripheral resistance increases blood pressure. So this one is what results into increase in blood pressure due to narrowing of the lumen. And another thing what happens is that these inflammatory mediators can trigger clotting, whereby the blood vessels begin to form clots, which we call the thrombus. So there is formation of clot. This is, we are calling it a clot, which in a medical we term it as a thrombus. So when there is thrombus formation, meaning we are using a lot of platelets. Platelets are being used up, and when blood is flowing, this one also can result into hypertension. But in case the blood moves it away and it begins saturating in the body, it can block the blood vessels supplying the vital organs. So this vesicular spasms or formation of the thrombus can result into blocking. This one can block the blood vessels supplying the vital organs, such as the kidney. It can block the blood vessels supplying the liver, the brain, the heart. This one can happen, which results into multiple organ damage. So, formation of thrombus and vasoconstriction, that is narrowing due to increased vesicular spasms. So increased vesicular spasms due to the inflammatory factors, together with induced formation of the thrombus, or that is a clot in the blood vessels, can result into the blockage of the blood vessels that supply the vital organs of the body. And when there is reduced blood supply to the kidney, this one reduces glomerular filtration rate, which results into a condition we are calling reduced urinary output, that is oliguria. And because of increased pressure, there is leakage of also proteins, which results into proteinuria. So proteinuria is brought about by oliguria, that is decreased blood supply to the kidney, which leads to decreased urinary output. It is due to blockage of the blood supply to the kidney, leading to decreased GFR, leading to decreased urinary output. You find urinary output is less than 1.5 liters per day. Then if it is to the liver, it is going to cause liver damage. And this liver damage will result into increase in liver enzymes such as ALT, AST, and LDH will increase. So it leads to elevated increase in liver enzymes. If it is the brain, this one can cause confusion, headache, and convulsions. It can lead to convulsions. And this one can progress if it is fully blocked, especially the carotid artery. It can result into stroke. It can lead to stroke and death. Then if it is the heart, if the coronary arteries are blocked, this one can result into heart attack what we call myocardial infarction. So this is how multiple organ damage failure comes. And if it is a problem with the blood supply to the eyes, this one can result into blood vision, and scotoma. So blood vision is, you find you cannot see properly. So it is one of other signs and symptoms. And among the signs and symptoms, we also have blood vision because the eye is affected. And you find someone who can no longer see very well the way the images appear. That is also another sign of preeclampsia. So this formation of the clot has resulted into reduced platelets. So it has brought a syndrome which we call HELEP syndrome. This one brings about a condition known as HELEP syndrome. And this HELEP syndrome is hemolysis. As the red cells are moving, when they hit on these clots, they break. And blockage of these blood cells leads to what we call hemolysis. There is hemolysis. Then there is elevated liver enzymes. Liver enzymes such as AST, ALT become elevated, then we see low platelets. So this is one of the complications that brought about by this preeclampsia. So the complication is multiple organ damage. We have seen HELP being also another complication, whereby we see hemolysis. Hemolysis leads to low HB, decreased blood red cell and decreased HB. Then we see liver damage, which leads to elevated liver enzymes. Then we see low platelets, always less than 100. That is one of the complications. Then complications of organ damage due to reduced blood supply. Then complication of the eyes, whereby we see there is blood vision. That is also another complication. Then the problem of pulmonary edema, which leads to shortness of breath. And then generalized edema, which leads about swelling of the lower limbs, the hands, and the face. And sometimes even the stomach can swell. This is what we call the complications. And apart from edema, organ failure, then blood vision, together with HELP, these ones can also result into preterm birth. You find another complication can be preterm. You can produce a baby with low weight. It can result into preterm delivery, whereby you deliver a baby before term, before maturity. Or it can result even into fetal death. And this organ failure, increased blood pressure, decreased HB, platelets, can result also into maternal death if not managed. These are one of the complications we can talk about. So after looking at the signs and symptoms, the complications, the risk factors, now we need to see how can we diagnose this preeclampsia. And among the diagnosis, we're going to talk about the diagnosis and treatment. So with the diagnosis, how do we test in the hospital that yes, someone has preeclampsia? And one of the diagnostic factors, what we perform is we measure blood pressure. And this blood pressure is measured on 2 different occasions. And these different occasions are done 4 hours apart. So when you measure blood pressure of the pregnant mother who has come in on 2 different occasions and it is 4 hours apart, and you find the blood pressure is greater or equal to 140, over 90 millimeters of mercury. This one is regarded as pre-eclampsia. Remember, it is after 20 weeks. But if you measure this blood pressure at two different occasions, you find it is greater or equal to 160 over 110 millimeters of mercury. This one is regarded as severe pre-eclampsia. This one is severe and it needs much attention. That is one of the diagnostic measures. The second one, we can do urinalysis. You can request, as a doctor, you can request urinalysis, and one of the things you are interested in is proteins in urine using a dipstick. And if you find proteins in urine greater than +1, this one can confirm preeclampsia in pregnancy. Or you can do a 24-hour urine protein. If you find it is greater than 300 milligrams per 24-hour urine, that one can confirm. You can go ahead and under macro, you can look at the foam on urine or bubbles, majorly foam on the top of urine. Then another thing, you can measure urine volume, and if it is less than 1.5 liter, that is what we are calling oliguria. This is what we are calling oliguria. So this is what some of the diagnostic measures we can do under urine analysis. Then another one, we can collect blood. We can collect blood, and on blood we can do a full blood count or a complete blood count. And if we find there is reduced HB, reduced RBC count, and there is reduced platelet count, this one shows there is formation of coagulation or clotting. So this shows that there is HELLP syndrome. Then you can also do LFTs, liver function tests, where you are interested on ALT and AST. Maybe together you can add LDH. So these ones, if they are elevated, it means still there is HELLP syndrome. You can also do renal function tests, where you can look at burn, blood urea nitrogen, and the creatinine. If they are elevated, still they confirm problem with damage. Then on the fetus, you can do intrauterine Doppler scan. If you find there is abnormal breathing rate, you can also do kick count. All these ones can be used to route these problems in preeclampsia. So these are some of the diagnostic measures we can always do to route preeclampsia. Then lastly, we look at the treatment. How do we treat these patients with preeclampsia? And the first thing we do is to manage hypertension. First, stabilize the blood pressure by giving antihypertensives like oral nifedipine. Can give oral nifedipine, slow release, that is sublingual. Then you can also give alpha-methyl dopa. Alpha-methyl dopa. Or if it is severe, you can give IV hydralazine. You can give IV hydralazine. So that one can happen. So we have seen you can give oral nifedipine. If it is not so severe, you can give alpha-methyl dopa. It is also good in pregnancy. But if very severe, we opt for IV hydralazine, because it can easily reduce the blood pressure. But you now must give it as a slow release, because it has a tendency of reducing very fast. It can reduce blood pressure very fast, which can result into stroke or hypertension and stroke. So you must be monitoring this pregnant mother as you are reducing this blood pressure drastically with hydrolysis. Another drug you can use is labetalol. Labetalol can also be used if not hydrolysis, but we have said this one is used in severe cases. Then if you have tested the patient has high blood pressure and you are stabilizing the blood pressure, we start you giving these pregnant mothers with magnesium sulfate. Magnesium sulfate is given to prevent seizures, or it is a prophylaxis being given to stop progression of preeclampsia. And we told the eclampsia is preeclampsia with the presence of convulsions or seizures. So this one is always given as a prophylaxis to prevent progression to formation of convulsions, or what we can call seizures. And if the fetus is less than 34 weeks, means they haven't grown the lungs. So you can always give dexamethasone. So a corticosteroid such as dexamethasone is given to enable lung development. This one enables lung development. So for the development of the fetus lungs, you can give DEXA, which is a corticosteroid, to enable it to grow. And as we are continuing to manage, in case you find this pregnant mother is before term and the child, you find them, the mother is stable. If the mother is stable and the fetus, here you continue managing blood pressure. You continue managing blood pressure and you can terminate or you can plan to deliver after 37 weeks, or you can continue to monitor until term reaches. But the problem comes if the fetus is unstable. With unstable fetus, maybe after doing a Doppler scan and the fetus is unstable, here that is when you give dexamethasone if it is below 37 weeks. Then afterwards, when the fetus reaches 37 weeks, you can plan delivery. Then if the mother is unstable, the mother is unstable, that is the mother, here you have to plan to stabilize the mother. Maybe the mother is having organ failure, is having dyspnea, that is shortness of breath, so if these are there, and maybe is developing seizures or convulsions, so the first thing you do is to stabilize the mother. And how do you stabilize? You can do ABC. You open the airway, you ensure breathing by giving oxygen, and you ensure there is saturation. After stabilizing the mother, you can give magnesium sulfate. This magnesium sulfate is to stop seizures, IV. As you are stabilizing these seizures, that's when you are planning the mode of delivery. You plan delivery. It can be by C-section, it can be normal, depending on the assessment, how you assess the patient. If the patient the previous was Caesar, you might opt for Caesar. Or if other conditions are normal, you can plan to deliver by normal. No wonder the age of the patient, no matter the age, or either it is after 37 or it is below 37, so long as the mother is unstable, you stabilize the mother as you're planning to deliver this baby, despite the age of the baby, because this is, with the seizures, this is an obstetric emergency. It is an obstetric emergency. So you must stabilize the mother and plan for terminating the pregnancy so that we don't lose all of them. That is what we can do by managing. So this is under treatment. how we can always manage these mothers with preeclampsia. And with medical education, we always urge you, when you are pregnant, always do regular antenatal care, seeking by measuring your blood pressure, looking at your blood pressure, majorly always monitoring blood pressure, doing urinalysis to rule out the presence of proteins in urine is always very important. Don't always change men is also another way of preventing this preeclampsia. And in case you have multiple fetus, you are having twins, always monitor the baby's kicks. You can always sit down and count the kicks of the baby. They should be not less than 5 in an hour. Always count the kicks of the baby, and we always also do the ultrasound scan to see the condition of the baby. So this is what we can discuss with you under preeclampsia. Thank you so much for learning with us at Medical Sciences. May God continue to bless you. Don't forget to share to many so that they can continue to learn.